good evening, everyone. Thank you, Dr. Rajeshwar and organizers for having me here today. And so for the next 15 minutes, I'm just very quickly going to walk you through essentially the role of precision medicine in treatment in the management of advanced NSCLC cases. So let's get started. We know, NSCLC, as we know, is possibly one of the most molecularly diverse cancers. And if just look at its evolution, right? You've gone from treating NSCLC as one large homogeneous group, and slowly you've moved on to categorizing it based on its histological subtypes. And again, from there, if we just focus on the adenocarcinoma subtype, it is very molecularly diverse. In fact, in around 3% of cases, there is more than one oncogenic driver mutation that is causing the disease. And this is, I think, in 2022, what the NCCN recommends, which is a minimum of EGFR, ALK, ROS1, BRAF, and PDL1 up front. And we've heard about them time and again, so I'm not going to spend too much time discussing them. What I want to do is using, I like calling them the OGs, EGFR and ALK. I'm actually showing you how we've actually evolved in biomarker testing. Even though we start with an EGFR, how there are so many other possibilities of biomarkers coming in, especially when a patient progresses. So, an unselected population, okay, from there you identify, let's say, an EGFR mutation, you put your patient on a TKI. Now, after a period of time, we know it's going to develop, some sort of a resistance, and there's going to be progression, so we use it to confirm it. We do a rebiopsy, preferably from the new metastatic site, or if rebiopsy is not an option, we know we have liquid biopsy. Irrespective of sample type, we send the sample for molecular profiling. Now, while we've identified that the most common resistance mutation in EGFR is the T790M, it accounts for around 60% of these cases. But in addition to this, you've actually got a host of other resistance mutations. You've got your meta amplifications, you've got your PIK3CA, you've got your HER2, and more importantly enough, you've got your small cell transformations. Similarly, when a patient, let's say, progresses on osimertinib, it acquires resistance mutations. Again, as we've seen in the AURA3 trials, around 15% will have a C797X mutation. However, there's about 19% that are positive for a meta amplification, HER2 amplification, which is around 5%. So as you can see, it's not just about just looking at EGFR, ALK, BRAF, ROS1, it actually evolves, and that's why getting a full picture becomes so important. And I like using this particular pie chart because it actually highlights all the biomarkers, the somatic aberrations that we see in the adenotype of NSCLC. So while KRAS mutations are common, particularly in our smoking cohort, there is a wide variety of somatic aberrations. And I use the word aberrations because some of them are fusions, some of them are point mutations. They have a variety of structural variants, and majority of these are easily druggable by obviously a plethora of drugs. Furthermore, what this does is it likes to divide tumors into what I like to call a beginner's guide to targeted box therapy. For tumors that are oncogene addicted, all you need to molecularly match them to the targeted therapy, and the tumor performs well. And then you have those tumors where it really doesn't matter what the mutation is, but that particular tumor is only addicted to immunotherapy. And when you get it right, it really works beautifully. This is a 59-year-old female. She's EGFR positive. She was started on Jefferson, and the patient showed remarkable response. She reported feeling much better. So when it works well. But something important with molecular targets is that they're highly effective, but they're not always curative. Now, very quickly, let's review the sample options for molecular testing. So we notice biopsy is the gold standard. No argument there. You do it, at diagnosis, you do a biopsy, at progression, you do a biopsy, preferably from the new metastatic site. However, the ground reality is, as much as I'd like my blocks looking like this, unfortunately, it does become an issue, especially in lung cancer. And to combat this, liquid biopsy is fast becoming an excellent alternative. So in a stage 3B or greater lung cancer, you can actually isolate the ctDNA, the circulating tumor DNA from the bloodstream. So ctDNA is the somatic DNA that is released from the cancer cell into the bloodstream, and this is what's isolated, and the tumor on molecular profiling gets done. Now, one of the key apprehensions or concerns with liquid biopsies we've had is its concordance with tissue. And now we've got multiple studies like the NILE, the SLIP studies, the PEN2 studies, which are very, which they've used clinical samples in advanced NSCLC cases, in that particular cohort, we saw it was a 98% concordance between tissue and liquid, which hereby solidifies that liquid biopsy is a good platform of choice in our advanced NSCLC cases. In addition to that, I do think that liquid biopsy does have a certain set of pros versus tissue biopsy. One is because it's non-invasive, you can actually monitor treatment response. You can call out those resistance mutations right in the beginning, and it helps address the issue of tumor heterogeneity. And there are a variety of validated platforms, technologies that are available to call out variants. But in my very humble opinion, I think NGS is fast becoming the platform of choice. So I'm not going to belittle the standard of care of those platforms like RT-PCR, FISH, IHC. What I feel is NGS, we get answers to the biology of the tumor in one sitting versus standard of care. And what NGS has been able to do is that it's becoming cost effective. The turnaround time has improved significantly versus serial testing. Is tissue preservation, because all you need is a minimum of 20 nanograms of good tissue, of good DNA, and you can run it on an NGS. But the key points that turn out that, for where I feel NGS trumps my other standard of care is that you have the potential to discover actionable targets. And in the pie chart earlier, I'd shown you that cohort of patients with 3% of them could have more than one oncogenic driver mutation. NGS helps call these out. And what this does, it helps guide and chart out a more personalized treatment for our patients. And this is where we are in 2022. It's a snapshot of all the biomarkers and the associated therapies. And you can see we've got some new kids in the block. So very quickly, we're going to get acquainted with them. So NTRK fusions, we know, are very rare. They constitute for around 43% of our NSCLC cases. They are agnostic markers. And as we can see in these waterfall plots for entrectinib and larotrectinib, they very beautifully illustrate the majority of solid tumors, lung cancer included, have responded well to TKIs. What essentially is happening over here, it's a rearrangement of the NTRK gene, which couples with what we call the tyrosine kinase domain at its 5' fusion end to generate chimeric TRK, a TRK protein ligand domain. In short, it has a fusion. Some of the most common fusions that we see in NSCLC is NTRK, we see it with TP53, CD74, TPM3, and NTRK3, we see it with ETV6 and EML. Now, how do you test for this? Now, this is the methodology that is recommended by ESMO, but in my very humble opinion, NTRK are translocations, they are fusions, be it 1, 2, or 3. NTRK3 has a very low staining on IHC, whereas NTRK1 has a low specificity and sensitivity by FISH. Thus, for me, the preferred platform becomes NGS. And RNA NGS, because it is a fusion. As we know, fusions have a higher sensitivity and specificity on RNA NGS, and this is the same that's being echoed in multiple international journals. Now, RET. RET is a gene that is synonymous with papillary thyroid carcinoma, but interestingly enough, it does constitute 1 to 2% of NSCLC cases. So again, the RET gene rearrangement, what it does is it gives rise to a chimeric cytosolic protein, which constitutively activates the RET kinase domain. Again, a fusion. The most common fusion partners we see is KIF5B, followed by CCD6 in NSCLC. Again, it's a fusion, so RNA NGS is your platform of choice. Your therapies are selpercatinib, which we get from the Libretto 01 trials, and we have pralsetinib, the blue 667, as it's easier to pronounce, is from the Arrow trials. And then we move on to MET exon protein skipping. Now, this is a mutation that occurs at the junction of exon 13 and exon 14, and this leads to the skipping of exon 15. So what you're essentially looking for is the product of exon 13 and exon 15 that gets formed. Again, a fusion, RNA NGS, and I just want to you just kind of put a shout out over here is that whenever your report comes negative, go back to your service provider and ask them, did you do RNA NGS or DNA NGS? If it is DNA as a reflex, please go to a service provider that is going to use RNA NGS. And not just for NTRK RET-MET, this is for your ROS1, your ALEX, as a standard rule. Anytime you're looking for a fusion, it has to be RNA NGS. Your treatments of choice available for MET is crizotinib from the Profile 1001 trials. You've got capmatinib from the Geometry and tepotinib from the Vision trials. Then we've got the KRAS mutations. Now, this is one of the most common mutations in NSCLC, around 25 to 33% of our cases, and especially this is common in our smoking cohort. what you're essentially looking for is a mutation that occurs in the GTP binding protein that connects with the receptor of the tyrosine kinase. Now, again, in KRAS, we've got different subtypes. The 12C is the G12C, is the most common. It constitutes of 40% of these KRAS cases. And what's very interesting about KRASs and all these subtypes are the varying TMB rates. So G13 has a high TMB rate versus G13, G12C. But interestingly enough, G12D has a low propensity for high tumor mutation burden. And even with the PD-L1, we see a variation with G12 and G12C and G12D. So I thought this was very interesting in this particular biomarker. And from the AMG 510 trial, we have sotorasib as our drug, and NGS is a platform of choice. Now, this talk would be incomplete if I don't very quickly mention the immunotherapy biomarkers, from the KEYNOTE 010, CheckMate 017, OAK trials. They've all very well demonstrated the utility of PD-L1, which is making it recommended biomarker upfront. We've got 3 clones, S22, DACO2233, SP1263, SP142. Based on the TPS cutoff scores, we see if a patient is a candidate for immunotherapy. Tumor mutation burden. For me, this is a slightly controversial immunotherapy biomarker in lung cancer in particular. So what's the key theory behind it? We say that every cancer's got a mutation, and more the mutation, higher the neoantigen, and possibly a better immune response. So in the lab, on a minimum of around 250 or gene panel, you look at the number of genetic aberrations in the exonic region, and this gives you the indirect idea whether or not the tumor you're dealing with has a high or low neoantigen load. And this is where I think there's a slight issue with again, this is just my 2 cents, with the theory is that not every mutation will actually cause the tumor to have a neoantigen load. And they may have antigens, not necessarily be neoantigen recognized by your immune system. So for me, the neoantigen may not really induce immune response. So I don't think the one-size-fits-all TMB score of greater than or equal to 10 mutations for megabase pair is ideal. I think like PD-L1, we have to figure out the right cutoffs for solid tumors. That's just my 2 cents. But I know that FDA has given a blanket approval from the KEYNOTE 158 trials. So, but if you are going to be using TMB, tread carefully. Try with Foundation Medicine. I don't work for Foundation, no conflict of interest. It's just that they have some great data supporting TMB, their TMB algorithm. And if you are going to be doing one of those in-house panels that's done, please make sure it's on a validated assay like Thermo Fisher or Illumina. And just very quickly for the next 2 minutes, I just want to sum it up by demonstrating through cases as to how biomarker testing has become so important in guiding treatments. Female, she underwent the typical sequential testing of FISH, IHC, RT-PCR, everything came back negative. She was young, non-smoker. We took a gamble, we sent her in for NGS, and she came back positive for a BRAF. So as I said, NGS increases your chances of actually calling out and finding actionable mutations. This is another case of a 79-year-old male, EGFR positive, was started on afatinib, progressed, did a rebiopsy, and no mutation was detected. 79, we really were not ready to start with chemotherapy, so we decided to send her for a liquid biopsy, and we found a MET exon 14 skip mutation. Now, this was obviously missed on the tissue, and there were a couple of reasons. A, the VAF was as low as 0.4%. And the reason is that on liquid biopsy, because our depth of coverage used to be a minimum of 15,000, 20,000 x, you have a higher sensitivity in calling out these really, really small these small variant allele frequency mutations, which are usually something like a MET exon 14. This is an actionable target, and the patient was started on capmatinib. And another reason there wasn't obviously a discrepancy is tumor heterogeneity. And my last case is an 81-year-old female, NSCLC. The tumor was insufficient, refused to go in for rebiopsy. This was on the onset of COVID-19 in 2020. So we sent her in for a liquid biopsy. She came positive. ROS1. She was started on crizotinib. She eventually progressed. Again, she refused to do a tissue biopsy, so we sent it in for a liquid biopsy. We saw that the ROS1 fusion persisted. She had acquired a ROS1 G2101E mutation. Now we know this is a very common crizotinib.
You are just left 1 minute to conclude.
Is it known? Sorry, just one second, I'm just wrapping now, is a known crizotinib resistance mutation. So the physician put her on lorlatinib. It was short-lived. She progressed again. So we again repeated a liquid biopsy. And we saw that while the ROS1 was persistent, she had lost the ROS1 2101A, but gained the ROS1 G2032R. In addition, we lost the KRAS K117N, and this time we had a KRAS 12D, which was a target in the form of binimetinib. But this is a reason I've highlighted this case is you've got to be aware of a potential CHIP mutation. So with ctDNA becoming a very fast actionable resource, we have to be aware that the sample we're getting is not just of the tumor in the patient's cancer. We're also seeing variants arising from both the tumor and from their aging white blood cells. And they've been identified as, let me see if I get this right, clonal hematopoiesis of indeterminate potential, CHIP mutation. No one wants to say that the wrong-winded name. They call it a CHIP mutation. And these mutations are not uncommon in patients with lung cancer, especially the older ones and those with history of smoking. Some of the common CHIP mutations we see in lung cancer is TP53, KRAS, and JAK2. If you see a VAF which is less than or equal to 1%, please beware. And I think this pie chart very beautifully summarizes my talk, where around 50% of our patients with NSCLC have driver mutations. And and we have these targets with an FDA-approved agent, or a lot of these are in clinical trials, the ones in red, but they're fast going to get approval by end of this year. And on that note, thank you very much for your patience. Thank you.